So I just want to disclose that I have funding from several different places right now. And I'm going to talk about the epidemiology of chemo-induced neuropathy, what the signs, symptoms, and the sequelae are of that, what the clinical practice guidelines are for our oncology colleagues, and the role of cancer rehabilitation in management of this. I'm also going to be talking about 4 new clinical trials that are up and running here in Illinois. Okay, oh, it's not letting me do that. Okay, okay, I see what I have to do. Okay, all right. So the epidemiology of chemo-induced neuropathy. So who's going to get it? Who's most affected by this? We know worldwide that the incidence and distribution of cancer is pretty huge. There's a total new cases right now that we estimate at just under 20 million patients worldwide. And we also know worldwide the top 4 cancers are number 1, breast, followed by prostate, followed by lung and colorectal cancers. There are also substantial amounts of patients with cervical or uterine cancers, stomach cancers, liver, ovarian cancers, and thyroid. These are the most prevalent worldwide. Oops, I keep hitting the wrong button. Sorry. In the US, though, we have 17 million cancer survivors. We know that by 2030, there'll be a 31% increase to 22.2 million cancer survivors. And that is going to be exceeded by 2040, where we're going to have a jump by just under 4 million more survivors at 26.1 million survivors. So it's a lot of people that are surviving cancer, living longer. And as a rehabilitation specialist, my job is to make that rest of our cancer survivors' lives at a much higher quality. All right, we know that 64% of our survivors are 65 or older, and also that female breast cancer survivors make up about 23% of all of our survivors in the US. 22% represent patients with prostate cancer, and colorectal is about just under 10% of all of our survivors. The reason why I highlight colorectal here, and you'll see references to it throughout the talk, is because our colorectal patients typically receive chemotherapy that is especially neurotoxic. And a lot of the studies on chemo-induced neuropathy have been done with patients treated for their colorectal cancers with this one particular platinum-based agent that's been studied the most. So what is chemotherapy-induced neuropathy? It's caused by cancer chemotherapy agents. So most notably, this means our platinum-based agents. Oxaliplatin I have in bigger letters is because it's a big one. It's used a lot. It's a real workhorse for patients with colorectal cancers, but it's also used for other cancers as well. And then two other types, carboplatin and cisplatin, are also problematic, but and those are used for other tumor types as well. But oxaliplatin is the one that's studied the most in this with this phenomenon of chemo-induced neuropathy. However, another class of chemotherapy agents, taxanes, which is often used with our breast cancer patients, is also another culprit of this, as well as vinca alkaloids like vincristine, vinblastine, vindesine, and vinorelbine. Chemotherapy-induced neuropathy is considered a neurotoxic adverse event, and that's something that is formally reported and recorded by your provider. If you begin to develop this, there usually is documentation of the development of it. So the neurotoxicity occurs through interference with axonal transport for the axons of the neurons involved with this neurotoxicity. It causes DNA and/or mitochondrial damage, and it alters the ion channel activity of these neurons. So we know that there is a kind of like a dying back phenomenon that can happen in the periphery, but we also know that there are other changes that can occur that directly affect the DNA and mitochondrial DNA and damage. I keep hitting the wrong forward button. All right. And I already mentioned how central neurotoxicity can also occur, and I'll touch on that a little later in the talk. So the incidence and the prevalence of chemo-induced neuropathy is mostly derived from what we know about individuals who've been treated with oxaliplatin. Overall, the prevalence of chemo-induced neuropathy is anywhere from 19 to 85% of patients that are treated with chemotherapy. Patients treated with platinum-based agents have a prevalence of anywhere from 70 to 100%, with oxaliplatin considered one of the most detrimental ones. For people treated with taxanes, that's anywhere from 11 to 87%. And those treated with zinc alkaloids are up to 20%. Acute neurotoxicity from chemotherapy in the form of chemo-induced neuropathy is that can mean that there's a prolongation of infusion time. There can be a overall reduction in the chemotherapy dosages that are delivered. And there can also be a frank discontinuation of chemotherapy, particularly when it gets really severe and intolerable. The incidence of oxaliplatin-based neuropathy in the acute phase is between 4 to 98%. I'm going to describe a little bit how that presents acutely versus chronically. Typically, there's a 3-day peak. If you develop it in the acute phase, there's a 3-day peak with a reduction in it. And then with each consecutive chemotherapy trial or chemotherapy cycle, there will also be an increase with the presentation of it, and then it will come back down, and it goes up and down like that in the acute phase. That's not the case in the chronic phase of it. But typically, patients will complain of, during the acute phase of it, that there's this hypersensitivity to cold, a sensitivity to swallowing cold food and drinks. There can be discomfort in the throat and muscle cramps. And there's a lot of complaints of these symptoms among our patients. The initial severity of peripheral neuropathy in the acute phase is a very good predictor of whether there will be a chronic presentation of peripheral or of chemo-induced neuropathy later on in patients. And this one study looked at patients up to 25 months after they completed their chemotherapy. So this is another study that came out just this year, actually, I think it was, that talked about the characteristics of acute and chronic chemo-induced neuropathy related to oxaliplatin. Patients reported 85 to 96% of patients that were included in this study reported that they had acute onset of peripheral neuropathy, and that it continued into the chronic phase for between 40 to 93% of those patients. The duration of it for the acute onset was within hours of infusion and lasting for up to about a week after the infusion, whereas the patients with the chronic presentation of it is that it developed within 6 to 12 months, and some patients reported it lasting for up to 5 years. The typical feature acutely was cold sensitivity. There were some motor symptoms, muscle weakness, muscle cramping, but with chronic chemo-induced neuropathy, they reported all of those acute symptoms, but also that it was relentless, like it never went down and then back up. It just kind of coasted along. And the mechanism for acute chemo-induced neuropathy among patients who received oxaliplatin was that there was a sodium channel activation. So these neurons were kind of, hyperactive. However, in the chronic phase, there was noted that since there was dying back neuropathy of the sensory neurons, there was mitochondrial damage. They noted oxidative stress. There was also activation of supportive neurons and neuroinflammation. Okay, I'm going to skip this one. I think I hid that slide, so I'll skip that one. And so this goes very nicely into signs, symptoms, and sequelae. And I have a nice picture later on of the acute onset and the chronic onset. So let me start reviewing the signs and symptoms. So there are 3 classes of these signs and symptoms: the sensory type of symptoms and signs, motor type, and the autonomic type. Under the category of sensory, those are the ones that I think patients and providers are most familiar with: the numbness, the tingling, the burning, the pain. But there's also a reduction in our in reflexes. So what we note when we do like a patellar tendon tap is that, often when the reflex is patent and normal, you have a nice little kick. However, with patients who have this kind of chemo-induced neuropathy, that the kick is either absent or it's very slight. So it's definitely reduced. There can be diminished or no sense of where your body parts are in space. That is, where your hands are, where your feet are. And that's really problematic for balance and fractures. And I'll talk about that in a little bit as well. There can also be diminished or absence of vibratory or cutaneous sensation. So, that makes it really difficult to be handling things like, if you're trying to, change the, like something I just did the other day, change the screw in your glasses. That's really hard to do. There's a lot of discoordination with that. There can also be a diminishment or no sense of discrimination between sharp and dull. So all of the tactile senses are affected by this. Our motor symptoms will often present as prolonged muscle contractions and muscle cramps. There can also be spasms or fasciculations, that is, a quick movement, like a shuddering of the muscle. There can be muscle weakness. There can be problems with walking because of that weakness. There's also postural and balance impairment, where it's difficult to maintain posture. It's difficult to maintain your balance when you don't know where your feet are, especially. And like I mentioned earlier with the hands, there's also difficulty with fine motor skills. The autonomic symptoms are things like constipation, urinary retention. There can be dysfunction for sexual activity, and there can be blood pressure alterations. These can be easily kind of explained away by other things, like maybe you didn't eat enough fiber, or maybe you just, were having a very busy day and you've retained your urine. Maybe you're just not in the mood for sex. I mean, there are all these different kinds of things that can explain it away. way. But when they're taken together, especially with the sensory and motor symptoms, that should key you in that we need to be thinking, okay, are we looking at a neurotoxic problem here as chemotherapy-induced neuropathy? So risk factors for chemo-induced neuropathy, and a lot of this comes from the oxaliplatin literature, that if having or being of an older age, being female, having a premorbid condition of diabetes, having anemia, hypomagnesemia also is a problem. Alcohol consumption is a risk factor. BMI above 25 is a risk factor. A larger body surface area is a risk factor. And cumulative dosaging, especially if you've had oxaliplatin, is also a risk factor, and the number of chemo cycles that one has had. There are also genetic factors related to this. So in addition to all those other things that we talked about, this is another review study that came out around the same time as the one that I just cited. But this one specifically talked about genetic polymorphisms with a change in these particular genes. And I'm not going to get into the detail of that, but know that there are several different polymorphisms that are associated with specifically oxaliplatin-induced neuropathy. And if you've been treated with that, it would be helpful to have that conversation with your physician to see if you can be tested for any of these, if you think you might be at risk of developing this. So remember when I talked about the acute versus the chronic phase? The acute phase of oxaliplatin-induced neuropathy, which we know the most about, is this is the most common. It can happen within minutes to days after the infusion of your chemotherapy. It typically lasts 4 to 5 days, but patients often say it's about a week, and then, oh my gosh, that week's over, and I've got to start all over again. There's also no coasting effect with this. It's aggravated by exposure to cold, and it presents most commonly as changes in sensation for the hands and feet, and often with the perioral region. Less common are things like difficulty with swallowing, the muscle spasms and fasciculations, and prolonged muscle contractions, but they can happen. In the chronic phase, however, though, it is common. It is dose dependent. So the more you have, the more likely you can develop this. And the coasting comes from the fact that the symptoms don't go up and then come back down, but they are sustained. There's increased intensity of this with continued exposure to the neurotoxic agent. Severity will increase after stopping, and that's the coasting problem, but it can eventually begin to come down. The majority of our patients who develop this will recover to, it may not go away all the way, but it will improve. And that's what this may recover to less than grade 1. That's what that represents. The typical recovery or the typical improvement will happen within 6 to 12 months. Often it can be irreversible. Even if it has improved, it may never completely go away, and it can also limit activities of daily living. And it presents similarly to the acute phase with the problems with sensation of the hands and feet. There can be sensory loss with this, though, in addition, and symptoms that are not related to temperature. So when does it happen, and how is acute different than chronic? I think I've already mentioned it, but here's a really good picture of it. So in this area where you see these cones, that's where the severity of the problem goes up and then it comes down. And each of these blue arrows represents a cycle of the chemotherapy. And you can see it comes up and comes down, and then there's no problem. And then the next cycle, it comes up and comes down. It's a little worse than it was, and there's a little less time between, or a little less time of pain relief with this, or relief both motorically and sensorially, and it will continue to go up. And then we begin to get into the chronic phase. The chronic phase is, you begin to enter the chronic phase when there is no change or no bottom improvement when it starts to come back down. And when it starts to come back down and remains elevated, that's when we've entered the chronic phase of it. Now, this makes it, having these signs and symptoms leads to a propensity, or leads to a higher risk for falls and balance. A study that was completed in 2012, that was probably the best study on this, it was a descriptive study, and it was looking at patients treated with taxanes or platinum-based chemotherapy like oxaliplatin. The sample size was just a little over 100. Most were female, which meant a lot of these patients were treated with breast cancer, but a lot were also treated for colorectal cancer. And they had a mean of just under 6 cycles of their chemotherapy, and the mean cumulative dosages was about 544 for the mean cumulative dose. And of their neurotoxic chemotherapy. Whoops, I hit the wrong button again. So in this study, they found that just under 20% reported at least one fall since beginning chemotherapy. What is important to know about the study too is that a fall was most definitely an event where there was a complete loss of balance that resulted in an actual fall to the floor. This does not include slips and trips, which is a problem that can also put you at a higher risk for falling, but it's most definitely related to balance behaviors. So I actually think that in terms of falls and balance, there's an underreporting of the percentage that is affected by this. I think it's actually higher than 20%, because this is just the one fall since beginning chemotherapy and didn't include slips and trips. So characteristics of fallers and the predictors of those falls included the cumulative dose of chemotherapy, whether they had presentation of these neurotoxic symptoms, these neuropathic symptoms. And also they had higher scores on the CIPN tool, the Chemotherapy-Induced Peripheral Neuropathy Assessment tool. So they had more problems with experiencing symptoms, problems with symptoms interfering with their daily lives. They had more severe muscle weakness, clearly had episodes of loss of balance, and this loss of balance had a higher interference with walking and driving, with the coordination that's required with driving. In this study, which was interesting, was that individuals who received taxane therapy were more likely to have falls than those with platinum-based chemotherapy like cisplatin or oxaliplatin. And the predictors of falls were reports of episodes of loss of balance and the number of chemotherapy cycles that they had. These were the two things that came out of all of this that were the most predictive of falls. Oops, I keep hitting the wrong button. Sorry, guys. So what does the presence of this mean for patients? And again, this study is one that included patients treated with oxaliplatin for their colorectal cancer. They had 101 patients treated with this, and they were divided between stage 2, 3, and 4, with the majority of these patients in this study having advanced stage 4 cancer of the colon or the or the rectum or the combined colorectal. So in this study, half of these participants had chemotherapy that was interrupted. And that's due to anything. It could be due to other toxic side effects of chemotherapy. It could be due to, having a family member that was quite ill and they had to take care of the patient while they were, holding their chemotherapy. However, a sizable minority of these patients had their chemotherapy interrupted because of their chemo-induced neuropathy. And they also had, whoops, I keep hitting the wrong button. They also reported these particular symptoms, numbness, tingling in the fingers of the hands and the toes and the feet. Those are the most common. They also reported pain and muscle cramps, and that almost half had difficulty manipulating small objects or opening jars and bottles. Half of them had dizziness with standing from sitting or lying, and of the men included in the study, about a fifth of them had reported problems with erectile dysfunction. The presence of neuropathy was also associated with the decreased quality of life. I mean, the next study that I'll be presenting talks about that. So this was a qualitative study that was done with 7 colorectal cancer patients, just to get an idea to describe a typical day that they have in living with their chemotherapy-induced neuropathy. They wanted to know, the researchers wanted to know the ways and the meanings that this changed their ability to move about in the world and what it meant for their own self-perceptions and identities and how that influenced relationships. So the first theme that they found was patients reporting unpleasant fluctuating sensation, which is impossible to ignore. This patient said, if I walk in thin footwear on cobblestones, I feel everything up through my body. I am walking, however, I am not walking in a safe way because it feels unpleasant. The second theme was breaking through noise and pain despite struggling to keep them at bay. When I have a lot of sensory disturbances, I often sit on my hands. This induces joint pain, which is easier to endure than the tingling, stinging, and warm sensation in the hands. So if I can't stand it, I just sit on my hands. So it's a distraction mechanism that this patient was reporting. The third theme was continuously feeling ill despite being cured, that constant reminder of that. And this patient said, the doctor said, can't you be happy that you are cured? However, it is difficult to be happy that you're cured or that you are cured because I've never felt so damn ill. And I've had so many patients that say that. The fourth theme was bodily constraints that impact self-understanding and limit the enjoyment of life. This participant was a musician and as quoted as, I've declined to play together with the others next Sunday at a concertina event. It was difficult for me because we were going to play a new melody and I felt unable, not good enough. Then knew, now this old man can't keep up with the others. So this is devastating for patients. But how are we able to communicate this to our providers? What are they up against? What are they looking for? How can I speak the same language as my provider to make it clear this is what's going on? So it's assessed in the clinic by oncologists, advanced practice providers, nurses, and rehab specialists. So we all take a clinical history. We all should know whether the patient has been receiving an agent known to cause chemo-induced neuropathy. We're all tuned into what these symptoms should be. Are they new? Are they worsening? Is it that typical numbness, tingling, or pain? Is it, does it also include the other symptoms, the motor and autonomic symptoms? There's usually a neurologic physical exam, testing skin sensation, testing reflexes. In some cases, patients may also receive electromyography studies or nerve conduction studies. But But typically, these kinds of studies, the EMG and the nerve conduction studies, are not done in patients that are asymptomatic who are receiving the neurotoxic chemotherapy agent. Usually this happens when the patient presents with that neurotoxicity, if they're even able to tolerate these tests. And while patients are undergoing their chemotherapy, they should regularly be evaluated for the presentation of a neurotoxic adverse event like chemo-induced neuropathy. And there's grading and reporting forms that are used for that. And we also use patient-reported outcomes for that. Earlier I mentioned the CIPNAT, that's one of them. So once it's detected, how is severity measured? This is that documentation of an adverse event that I mentioned earlier. And this is required by, for studies that are looking at this and also for evaluating or adhering to treatment guidelines too, using this event reporting terminology. Grade 1 is the symptom or the adverse event problem, like the neuropathy, is mild or asymptomatic. With mild symptoms, there can be clinical or diagnostic observations and no intervention is indicated, so it's really mild. Grade 2, we begin to increase with that. It's moderate. There can be some non-invasive intervention indicated, but the key thing with grade 2 is that it's now beginning to limit age-appropriate activities of daily living, like dressing, driving, balancing your checkbook, manipulating a pencil, all of these instrumental IADLs, dressing, bathing, eating, getting through the day. Grade 3, we're now in severe territory. That's medically significant. It is not immediately life-threatening, but hospitalization may be indicated, and it is severely limiting self-care, basic activities of daily living, and it's beginning to be disabling. Grade 4 is life-threatening, and grade 5 is. So how's it treated? Do we do rehab or do we not do rehab? The latest guideline from the American Society of Clinical Oncology talks about the prevention and management of chemo-induced peripheral neuropathy in survivors of adult cancers. So their question that they asked with this guideline is, what are the things that are recommended to prevent and treat this stuff in our adult cancer survivors? And so the upshot of this is that even though the current guideline is primarily focused on means of preventing this or treating that which is already established, they do recognize that chemo-induced neuropathy can involve physical dysfunction, that these patients often have balance problems and a much higher chance of falling. Therefore, they recommend to consider physical therapy and/or occupational therapy for patients with chemotherapy-induced related disabilities. So there are several things that ASCO recommends. Clinicians should assess the risk and benefits of the agents that they're going to deliver to their patients to begin with. Clinicians should, they also are very strong in their language about what should not be given to their patients in terms of supplements. But outside of the context of a clinical trial, they couldn't make any specific recommendations on the use of the following interventions. In green are things that physical therapy can definitely is stuff that we do, and in yellow, it's stuff that some physical therapists will do. This is the list of all of the supplements and medications that are not recommended right now, and I'm going to skip through that. And they also say that if chemo-induced neuropathy begins to develop, that clinicians should assess and discuss with patients the appropriateness of delaying dosaging, reducing their dosing, or stopping chemotherapy. So remember when I talked about that study that looked at interruptions of chemotherapy, this is what we're talking about. So for treatment of it, again, there is medication that clinicians can offer, but they also cannot make any specific recommendations for the use of these following treatments that can be administered by physical therapists. Acupuncture, some physical therapists have. Scrambler therapy, some physical therapists have. It's not widespread, but it is available among by some physical therapists. Okay, I'm going to skip over this because it basically repeats what I just mentioned. So the role of cancer rehabilitation right now, the standard of care for our cancer patients doesn't include rehab. It's not even on the radar. The main thing is survival and having this patient survive their cancer. Referral to cancer rehab is typically still largely reactive. It's when things get so bad that rehab needs to be called in, as opposed to working with rehab for a plan for recovery to mitigate these issues. So collaboration with a medical oncologist and a pain specialist for chemo-induced neuropathy is really is a very powerful approach to early detection, management, and navigation of the healthcare system to work on this. The preferred providers of cancer rehab services for this condition are, per the ASCO and NCCN guidelines, physical therapists and occupational therapists. And on the right are all the different kinds of interventions that we can do. I'm going to highlight the one therapy, Scrambler therapy, if we have enough time. Well, here we go, Scrambler therapy. All right, so it's actually a device. It's kind of like a TENS unit on steroids. It has a lot more channels, a lot more options, and it basically substitutes pain information that's being produced with synthetic non-pain information. So it's kind of like a big fancy electrical distraction mechanism, but while it doesn't override the pain, it does interfere with the perception of the pain, and it actually helps, we think, to remap the brain's reaction to the neuropathic pain. So it doesn't inhibit pain transmission. You can still feel sensations. It just works to help reduce the centralization of these painful pathways and to break the cycle of pain. And it is FDA approved, and it's also approved in Europe. Oh, sorry, I didn't want to skip past this. This was one of the first studies that came out to show how effective it is for treating patients with chemo-induced neuropathy. This was a study, I believe it was just on breast cancer survivors. And it was, I forget the size of the sample, I think it was like around 70 some patients, that it actually found that there was a reduction of almost 50% in pain across time, pain or in the symptoms of pain, numbness, and tingling, which is substantial. If you live with this, you know any reduction is great, but a 50% reduction, we'll take it. There are 4 clinical trials in Illinois right here that are open and are recruiting right now. 2 of them are non-invasive trials. The first one is looking at the effects of exercise on chemotherapy-induced peripheral neuropathy. It's being run out of the University of Rochester, but it's being, the 2 sites that are nearby are Decatur, Illinois, and also in Dayton. Another study that's going on right now is the use of transcutaneous electrical nerve stimulation, also known as TENS, for chemotherapy-induced peripheral neuropathy. This study is also being done through the University of Rochester. It has 2 groups, those who get TENS, those who don't, and again, it's being run through Decatur. Then there are 2 drug trials that are going on. The first is the treatment of established chemo-induced neuropathy with N-palmitoyl ethylamide or ethanolamide and a cannabinoid nutraceutical. It's a randomized double-blind phase 2 trial. It's run by Mellor Davis at the Academic and Community Cancer Research United Group, and it's being trialed through the Carl Center Oncology Research Program in Urbana. Then the last one is duloxetine to prevent oxaliplatin-induced chemotherapy, or oxaliplatin-induced chemotherapy-induced peripheral neuropathy. The study chair is at the University of Alabama, Ellen Lavoie-Smith, and there are 4 different arms, 2 experimental arms, 2 comparator, 3 experimental arms, 1 placebo comparator. I'm sorry, 2 placebo comparators, so it's 5 arms. This trial is a little complicated, but it is being run through Northwestern right now. My colleague Sheetal Kircher is the site PI for that. All right, and that